while I'm kind of getting my technology, okay, that worked. So I'm Lelia Wood, and I'm here from the University of Texas at medical branch in Galveston. I actually live in sunny Austin, Texas, which is not so sunny today, but I'm here from the Center for Violence Prevention, and I'm really excited to be here. So I'm a researcher. That's my current gig. That's my role right now. But before that, I was an advocate myself, and I worked in domestic violence, transitional housing, and I did violence prevention work. And I also have done sexual assault, hospital accompaniment crisis work. So this is near and dear to my heart. Alongside with this, and I don't normally share this in presentations, but for this group, it's really exciting for me to be able to share this, is that my mother ran a transitional housing program for 27 years, as well as running a child care in a domestic violence program. And my sister works at a state coalition. So this is an issue that my family is really passionate about, that I'm really passionate about. And in my work at the center, I do a lot of different work on our core sexual assault, domestic violence services like shelter, counseling, advocacy. In particular, I look at advocacy and advocates. And I really do a lot of evaluation and community-based work to try to understand how we can improve our practices, how we can meet the needs of survivors, how we can meet the needs of staff. So I've had a core belief in that work that one of the best things that we can do to improve survivor outcomes is to improve advocate work conditions. And I'm using advocate as like a very broad term today. I'm using it as a term to really talk about our workforce. So a lot of my work has been focused on advocacy and advocates, but I'm also, a lot of the data I'm going to share today and a lot of the information I'm going to share today are people who are from people who have a variety of positions in the movement and are doing a lot of different work, whether it's core case management advocacy or counseling or child work or legal advocacy, a lot of different roles. I am not sure if I will, is the Q&A enabled for this chat or for this session? Or will people use the chat?
They can use the Q&A or they can use the chat.
Okay,
and we have monitors to help us make sure to keep track of all of the questions.
Okay.
It does awesome. Look like you may already have a question. Cassandra Brown, did you have a question that you wanted to put in the chat? Oh, no, okay. Just checking. All right.
Okay, great. So I am the fourth of 5 children, so please interrupt me with questions at any time. I'll be talking first about some data that we have collected or that I've collected across several different studies to kind of get to the point where we got where we, today I want to talk a little bit about a pilot program we have going called Supporting Advocates, and it's here in Texas. We have been providing some counseling services to some of our advocates post-COVID. And I'll talk more about that, but I want to talk first about how we got here. So prior to COVID-19, several years ago, we began doing some work in Texas looking at the state of our workforce. And some of the things that we were interested in was really about occupational experiences and occupational stress. So I have some of these acronyms up here. I'm going to stop and describe them a little bit when I get there. This work that we did, which was called the Voice Survey, and I have the link there, it was done in partnership with our Texas Council on Family Violence and the Texas Association Against Sexual Assault, so our 2 state coalitions. And what happened was really we were at a collaborative meeting together and folks were talking about advocacy, stress, and turnover, and some of our kind of core issues. And what happened was we realized we didn't have a lot of data about how these issues were impacting our workforce, or even kind of like what the state of the workforce was. So what we did was we surveyed over 500 members of the Texas domestic violence and sexual assault workforce. So this is just Texas specific, though I would tell you from, working with all of you across the state, oh, somebody's actually read the voice survey. Oh, that's awesome. Thank you. I'll just say that I would be surprised if other states didn't have similar issues. Well, and I see I have a little typo in my presentation, but one thing that we found on the voice survey was we found really high rates of, that should say mission attachment, but we found really high rates of mission attachment, compassion, and job satisfaction. So let me talk about those really quick. Mission attachment is basically, you've got your organization's mission or focus. How attached is the worker to that mission or focus? So our workforce is highly attached to the mission, which typically is something to reduce domestic violence or end domestic violence. Compassion satisfaction is kind of the opposite to compassion fatigue. And what it really looks at is, are you getting satisfaction from the work that you're doing alongside job satisfaction? But do you have compassion fatigue, of course, is this idea that you're putting out a lot of emotional energy, you're doing a lot of emotional labor at work, and you're fatigued, you're maybe burnout, which is kind of a separate construct. So compassion satisfaction is the opposite of that. And then, of course, job satisfaction. We also found that along with these really positive things, like mission attachment, compassion satisfaction, and job satisfaction, we had really high rates of burnout and secondary traumatic stress. So let me talk about those two constructs because they're slightly different. And you've probably heard the phrase vicarious trauma and some of other phrases that are used in the field. I use these two because I think while they're similar, they capture. It's okay. I do that sometimes too, Cassandra. I think that the burnout is that, and I think we all might be thinking about that right now, especially post-COVID. Burnout is that feeling of emotional and physical, sometimes exhaustion, just really when you're having, a lot of work stress, you're feeling kind of, sometimes they describe it as depersonalization, just kind of like, oh, I don't, you can sometimes hear burnout when somebody's like, another person that wants a shelter bed, or, it's basically when those clients, you're so overwhelmed, you're so worn out that the clients don't have as much dimension and it's just all work. Secondary traumatic stress, some people define as the occupational partner to post-traumatic stress disorder. So it really looks more like trauma symptoms with secondary traumatic stress that is rooted in the occupational experience. So one of the other things that we looked at was turnover intention. So turnover intention is the best predictor of actual turnover. So why were we looking at turnover intention? Turnover is, as many of you who run nonprofits or work at nonprofits, work with survivors, that turnover is a big issue. It's an issue in terms of organizations and worker health and how an organization runs, but it's also really hard for clients. I interviewed a woman the other day who had 5 CPS caseworkers in 6 months. And she said, how could I even keep track of them, let alone get any help from them? So when we have a lot of turnover, we see that client services, the quality of client services tends to decrease. So we were looking at turnover intention, which is the closest predictor of actual turnover. And what we found was that higher rates of burnout, lower salaries, and identifying as Black was associated with higher turnover intention. This is really problematic for a couple of things. We're going to talk about microaggressions and workplace climate in a minute, but that's really telling us a little bit about, in this particular time of the study, and I would argue it hasn't changed much, the role of racial injustice and microaggressions in the climate for Black advocates in Texas and other states too. Low salaries, which is a kind of a chronic issue in our field, being one of the big kind of predictors of turnover intention. So we see that right off the bat, one of the most predictive things. We did see that things that predicted higher job satisfaction, which, when you have turnover intention, one of the things that can reduce turnover intention is, first of all, pay and equitable work climate and lowering burnout, but also having job satisfaction. So we saw that really increased use of coping skills, the workplace community, and lower secondary traumatic stress. That's what predicted job satisfaction. So we have a couple different things. Yeah, and I think, so there's a great comment in here about, not really being treated as professionals. We hear a lot about that with DV work because we don't get the funding or legitimacy. And I say DV sometimes as short. I'm talking about sexual assault work. I'm talking about human trafficking work. I'm talking about victim service work, survivor service work. We don't get the funding or the credit that a lot of occupations do. And we don't even get classified as first responders. We absolutely are first responders. We're responding on the scene. So I think that there's some of these kind of things that, you've got this workplace climate, but you also have a community climate of not only invalidating violence, but invalidating workers and their experiences. And part of that is by not paying them very much. So this was one of the kind of foundations that we had going into COVID. We also found on that same study that coping skills were really important. So we talk a lot about self-care, and sometimes we, kind of make fun of it, like, journaling and taking a bath isn't going to help me that much. Coping skills are different. It may look like journaling or taking a bath, but coping skills can be a lot of different things. It can be going to therapy. It can be engaging in political activity. It can be having peer support. It can be having a really robust social network. It can be things like massage, exercise, things that help you take care of your physical self. Coping skills we learned is really important. The other thing that we learned, digging in more, with that really concerning finding around Black advocates and their experiences, is that microaggressions more broadly were having an impact on people's, microaggressions predicted burnout and secondary traumatic stress. So we're seeing not only is microaggressions predicting burnout, but it's basically predicting trauma type symptoms. We also see that recent life events, and let's talk about a recent trauma we've all mutually had, COVID-19. And I don't know if there's any folks in here from Texas and from Louisiana and Arkansas and surrounding Oklahoma. We had the winter storm that our states were not prepared for, which was really tough for programs. So we had, all these events, even, a death in the family, a divorce. Those are the things that are predicting burnout and secondary traumatic stress. What's not predicting burnout and secondary traumatic stress is being a survivor. So there's this kind of idea in the field that there's some controversy, I would say, in the field about, do survivors make good advocates, and how far out from their survivorship do they need to be? And, we have not found across several studies that having a survivorship history is predictive of higher rates of burnout and secondary traumatic stress. So I say that because I think it's very interesting kind of information. I have some of the articles here that some of these findings are listed in. So we had that bucket of knowledge, and then COVID-19 happened. So we knew that recent stressors were going to increase burnout and secondary traumatic stress for our workforce. We also had, kind of, some people have called it the other pandemic of racial injustice. And so we've got all of these factors coming together, knowing what we know about microaggressions, knowing what we know about, kind of the climate for Black advocates, and probably Latinx advocates, Asian advocates as well. And then we've got COVID-19, where we've got, by all accounts coming out, an increase not only in domestic violence, sexual assault, but an increase in severity of cases. And then we have dwindling resources, right? Many of you who worked at shelters probably had to reduce your capacity. You probably had to take less folks in. You probably had to turn people away at higher rates than you would have before. So we see all of this kind of happening around the context of COVID-19, which, knowing what we knew from previous studies, makes us think about the risk for secondary traumatic stress, because you've got increasers of stressors at all fronts. Let me dig in a little bit to some of the work that we did, really understanding advocates' experiences. Oh, I just said all that already. But basically, we knew that there could possibly be occupational kind of impacts for advocates, and we were hearing from the state coalitions. I work really closely with my state coalition, the Texas Council on Family Violence and the Texas Association Against Sexual Assault. I love them. I work with them. They always have the best ideas. So what we decided to do was try to get some rapid data right away. So last year we fielded a survey, and this was a national survey. We use social media to kind of distribute it. We use coalition listservs. We use any means we could get to try to get to advocates. We probably had more success because it came out earlier, and then you all got really over surveyed over the last couple of months. So I appreciate how much troopers you've all been. So what we did was we basically designed a survey that had two different pathways. And the pathways were, one was for people with like active safety concerns. So that was so we could survey survivors. I'm not going to talk too much about that data today, but all that is to say that we wanted to try to hear from survivors right away, of course, too. And then we hit the staff pathway, which is really understanding what about work and health. And this was early days in COVID. So it was, kind of like, can you get access to a test? Do you have PPE? I mean, last April, those were all the kind of big salient issues. And then client safety and safety strategies, what folks were doing. And then work adaptations, technology, and work stressor. So I'm going to talk a little bit about that data. First, I'll just share a little bit about that first pathway. We had about 53 participants in the active safety concerns pathway. And at the time, this was like confirming what we were hearing anecdotally, that relationship difficulties were increasing, safety had decreased since COVID started, and people were starting to lose their jobs. So now we have a lot more data, and we know all of these things we feared happened, and they happened worse for survivors, especially for survivors who are people of color. So we've got, kind of some pretty strong grounding now. So, but back in June, this was some of our early indicators. One thing that we heard a lot about was just safety concerns, especially from schools being shut and custody exchanges being altered and some of those things. We also just heard about health concerns, people losing their job or being afraid to go to work. Again, this was back in April, May, when we didn't have as much information about how COVID was transmitted. So there was just a lot of unknowns, a lot of fear. The other thing that we did was we surveyed about 500 staff members. So this was open to anybody who identified as violence prevention intervention staff. And you can see it was vast majority, 70%, domestic violence, sexual assault oriented staff. And then we had child welfare and human trafficking, legal aid, and other. The majority were essential workers. And really we saw that the overwhelming majority of this sample reported that survivor safety had decreased. They also reported higher stress at work. 81% reported higher stress at work. So if you think about, what your life was like in April and May, I'm thinking, well, actually, I don't know if people can chat in, like, what was happening in April and May? You were pivoting online, you were trying to figure out where your clients were, you were trying to reduce shelter size, maybe thinking back to some of your concerns then. At that time, we had 22% of people that didn't even have access to PPE. So really what we saw in this kind of rapid analysis was that folks, just trying to get through it every day, right? I mean, I think it was just a different, we did follow-up interviews for this, and it was like, it was just changing all the time. So just focusing in a little bit on domestic violence, sexual assault staff, what was remarkable about this particular group that we focused on was not only were they having all these workplace stressors of like, how do I Zoom with clients? How do I find this teenager? What are we doing? And I think one of the things, I've got my kids at home. Yeah, I had that too. I have my kids at home with me. How do I meet with a client confidentially? Where's the space in my house where I can do that? One of the things that we found was that advocates were having a lot of resource issues themselves. We have 147 respondents who were having problems themselves accessing enough food or needed supplies, who had a partner who had been furloughed or laid off, and the income in the family had drastically reduced. And then the difference in shifting to telehealth, which some people had done and were kind of like pioneers of, and then some people had no experience and had to just learn all of this and select a platform. So the stressors were really high. Yeah, and some folks just got furloughed from their position, didn't know if they were going to have a job. Yeah, absolutely. Yeah, it does seem like another world. I mean, I'm glad it feels like another world now. I guess we're in a new world and, has other kinds of things going on. So at the time, this data really served in our understanding of, what kind of stress was happening for advocates. And what we thought this looked like, especially when we looked at this, is that it was gonna be like the recent stressors we'd found on the voice survey. So it was gonna look more like acute stress that was gonna increase risk for secondary traumatic stress. So that the kind of intervention that would be helpful was gonna be an intervention that targeted those kinds of approaches. Now, I'll tell you, and I just wanna recognize Karen's comment, which is, we brought all those traumatic conversations home. Absolutely. And some of the work that we were doing, especially with hotline advocates, they were answering hotline calls at home. So you all of a sudden have no separation between active crisis and your home sanctuary, right? Whereas maybe before you went to an office or you had a routine or a ritual that kind of separated all of these things. So not only was establishing safety and economics and resource loss a big issue for participants, just having support. A lot of people were used to being around their coworkers. So one thing that we learned from Voice and some of the follow-up work on that is what kind of gets staff by in a stressful work environment with really low pay is each other. Peer support, right? We encourage survivors to do a lot of peer support. It's great for advocates and staff too. It's one of the things that I'm going to talk about here in a minute, but peer support was a big issue. And then all of a sudden, everybody's working from home, and maybe you have a Slack channel, maybe you have an active text thread, maybe you're Zooming every day, but that peer support just kind of dropped out from its conventional form. And also for many of us, we lost a lot of our parenting supports because maybe the daycare closed down, or we had, school was online. So we're facilitating school online and we don't have our occupational supports around, and domestic violence is going up. So just a lot of increased stress. We had several studies in the field at this time, and we just kept seeing that there was increases in need, there was increases in domestic violence, there was increases in stressors for staff, and what started to come up over and over again was turnover issues. Now, I do want to just ask in the chat if people can just chime in about how your agency's been affected by turnover. Because one of the things we started to see was, and turnover happens for good reasons, right? Sometimes people are going back to get their master's, or they're, kind of going to do other stuff that's really positive, or they get promoted or whatever. But really just having intensive amounts of turnover, sometimes not in the actual victim service or survivor service arena, but sometimes like I mentioned about CPS, like I mentioned about other things. You know, just the turnover in the community impacted things. Yeah, so I'm seeing some different experiences related to turnover. So turnover started creating a lot of additional stress for people because, you know, we heard about a lot of turnover from older advocates who just did not want to risk their health pre-vaccine when they were essential workers who needed to go on site. So I'm going to talk a little bit about the pilot program that we started as a result of all this. But before I do that, I just want to say something that I think, so I'm talking about this pilot program today, but I want to say that if I had my druthers and they gave me, you know, access to all the resources, I would say, yes, counseling is absolutely critical, but I would also say that the two most effective things organizations could do to improve turnover, improve advocate experience, improve client services, improve occupational experiences, the number one thing is to increase pay. And if you can't increase pay, then you want to increase leave, you want to increase benefits, anything you can do to more accurately and fairly compensate workers. The other thing is working on workplace climate. And I know a lot of us have been engaged on different different kinds of activities to work on racial justice in the movement. But really addressing not only racial injustice, but disability injustice, heterocentric views and attitudes. Really, we're looking at kind of making sure the workplace climate is really safe for everybody, it's equitable for everybody, and really checking white privilege in those arenas. So, you know, those are the two most impactful things we can do. Now, one of those is change work that we're hopefully all engaged in. The other takes resources. So somebody said more staff to handle demand. Yeah, it's also a money issue. So like sometimes people bristle when I say that because they think, well, Leila, I just don't have the money to do that. So, you know, alongside increasing pay, increasing equity, some of the other things that we can do to facilitate a better work climate are around support. So while it's not a focus of this particular program, in our kind of 2.0 iteration, it will be, peer support is really critical. So I think a lot of us learned that working at home during the pandemic might have been great for some of us, might have been great for our athleisure collection, but for a lot of us, it really lacked the support that we needed to get by. So peer support, you know, a model that we really recommend for survivors, turns out to be great for advocates too. So let me tell you a little bit about the pilot program that we started. So this was a partnership with the Texas Council on Family Violence, who had a small amount of funds from the CARES Act that they were able to use for this initiative. What we wanted to do was kind of target those trauma-related symptoms or secondary traumatic stress-related symptoms. We wanted to open this to frontline workers, and we use that phrase very broadly. I'm happy to answer any questions about this. For a brief counseling intervention of up to 6 sessions completely free. We wanted to make sure that the sessions being provided were provided by phone or video, with the idea that anybody would be able to participate anywhere they were in the state. So Texas, like, you know, many of the states represented here, Texas is a big state. It's a state with a lot of different rural and urban elements. So even if it hadn't been during COVID, this would have been an important part because, you know, if you're driving from one side of Houston to the other, that can take you an hour, hour and a half. So really we wanted it to be very accessible, especially if we were going to continue it after you know, people started seeing each other face to face again. At the time, we didn't know how long that was going to take. And then really that services were good because it's a pilot program. Services were going to be first come, first served. So what we did was we had this small amount of funds, and we partnered with 2 providers. I'm going to tell you about the providers because they were really different. The providers, the first provider was a culturally specific provider that was focused on empowerment, evidence-based counseling programs, particularly focused for women of color or female identified people of color. And that was Prickly Pear. So Prickly Pear was one of our, kind of like the first people we reached out to, because they're doing a lot of work in the community around, this is an agency that's run by 2 clinical psychologists who have background in domestic violence, sexual assault work. One of the things we thought was really important coming out of the gate was that the counselors providing services not only had knowledge about domestic violence and sexual assault, because we just thought it wasn't going to be a really rewarding counseling intervention if you weren't able, if somebody had kind of regressive attitudes about domestic violence. But we also wanted people who were maybe familiar with that work context. So we had Prickly Pear, which is a relatively small shop. The other shop that we engaged with was Minds and Associates, which is an EAP network that provides counseling. So one of the things we've learned from this project is not all EAP networks are built the same. Some EAP networks are, providing more lifestyle support, dietary support, conflict mediation, and some EAPs provide evidence-based counseling. So at Minds is one of those, and they have a network of providers. So at Prickly Pear, people were matched with a provider, and Prickly Pear reached out to the advocate to schedule. At Minds, people reached out to Minds, and Minds provided a list based on their preferences. So we had 2 different approaches to how people got matched with their counselor. Both of these providers had diverse counselors from diverse backgrounds, and had counseling available in English and Spanish, counseling available by video and phone, and for Minds by text, and counselors a slew of counselors that were LGBTQ friendly. So we set some additional parameters. So everybody at Prickly Pear met all of our criteria, because it's a small shop. It's like 5 counselors. So we were good right there. Minds is a larger network. So we asked them to cull their list. So when people called and did a brief intake, they would be provided a list of providers. And we asked that only people with certain criteria be provided on that list. And that was counselors who had experience doing trauma work, counselors who had experience with workplace stress expertise, that were telehealth providers, that could do brief counseling models. And then we had a strong preference for people that reported experience with domestic violence and sexual assault. Any questions about the providers? Okay, I'll be monitoring here for questions. So what we did was, after we got our providers lined up, and the kind of process lined up, what we did was we sent out, we had 2 pilot agencies that we worked with first. The 2 pilot agencies were basically just to make our referral process work. So we had a secure Qualtrics link that was embedded in an email that went to employees. Employees were able to sign up through that email without their employer knowing that they'd signed up. And then our independent shop, UTMB, matched them with a counseling provider. And then they either, depending on the provider reached out to them, or they reached out to the provider. They would get an email with relevant information about how to do all of that. So we started with 2 agencies, and just to make sure that flow worked. And we picked one large agency with many, many staff and service components, and we picked a small rural agency. After we got that process refined, there were some early hiccups, especially in kind of figuring out, okay, what language works the best for instructions about how to reach out, how long should we give people to reach out to schedule the counselor, some of those things. What we did is we did a larger blast through social media and through TCFE. So we didn't want to rely only on executive directors to get the information out, because first of all, we know that they're busy. And then we also know that sometimes there can be gatekeeping issues. So one of the things that we figured out is that we wanted to have a larger blast throughout the state that would get advocates at a bunch of different places. So a group like this would have been, you know, if we had a national program, that would have been like an awesome kind of thing to do. So we were able to send several different messages promoting the program with the direct sign up link in a lot of different places. Okay, so when preferred, about providers, when preferred, survivors themselves are experienced working with survivors. So it was interesting. We definitely emphasized working with survivors as having experience working with survivors as a, you know, that was kind of the DVSA experience one. We did not specify a survivor themselves. We were really interested in having providers that had done domestic violence, sexual assault work themselves, had worked in that context. We were lucky to get a few, and we had a few that didn't have that experience. So that was a little bit of how we did that. We know that, you know, from other work that we've done, that about half of our workforce identify as survivors. So I think that that's important to have that background, especially working with survivors. So we did an evaluation format that was like a pre-sessions, you know, before you start your session survey, and then we're doing a follow-up survey, and then a 3-month follow-up, and then we're also doing interviews. So I'm going to share a little bit about what we've learned so far since the program is still active. So we had cap space for 60 participants, and we've filled 55 of those spots. We have at any point had 62 to, you know, to 65 participants, but people have been unable to kind of participate for different reasons after initially signing up. So, you know, we have 55 people that have engaged in a session at least. Most of these folks, so we said you need to have a frontline role. And then really what that means is that you're considered an essential worker, or you have some kind of role at the agency that's considered essential. And mostly what that's been is advocates, case managers, counselors. We haven't had anybody sign up that we've had prevention educators. They provide frontline services, in my opinion. So we've used that really liberally. And if I was doing this again, I would probably just open it up to all staff, because I think some people got tripped up by that initial eligibility criteria. We also initially had an eligibility criteria that was around if you had an EAP that provided counseling, you were not eligible. We removed that because what we found is that not all EAPs are built the same, and that some EAPs provided counseling, but were it wasn't trauma counseling, it wasn't high quality counseling, it wasn't culturally relevant or culturally sensitive counseling. We also found, and this is like the most important takeaway, I should have had a whole slide about this, is that advocates report again and again preferring to have an external counselor, not through the EAP. So EAPs can be good for a lot of things, but for having the counseling about work be funneled through work was really not ideal for people. What they liked about this program is that it was external. So, you know, similar to what we found on other studies that, you know, on our first COVID survey, is that most of the folks on their pre-surveys, before their sessions have even started, report that work stress has increased, that client safety is worse, and that their main goals for counseling are coping skills, help with life stressors, and to discuss work problems. So I'll just leave this up here. So we're starting to do interviews to learn more about, and as people, this is, you know, I really want to open it up to questions as we start going through some of the feedback. So please share any questions you have. What we found is that providers have really enjoyed working with this group, in that it has, you know, people have a lot of stress related to COVID, but part of what's coming up in these sessions are things that happened in the past. So past traumas, past experiences that maybe because our staff don't get paid a lot or they don't have a lot of service access, people haven't had free counseling. They haven't had an opportunity to go to a counselor. And especially for the situation with Prickly Pear, where we had the match kind of there, and they were very much advertised as a culturally relevant organization where you directly got matched to people. People really appreciated that, and that kind of easing the gap of their work, their just busy work lives of just getting matched with a counselor. Now, some people, of course, love the choice aspect of mine. So there's really, it was good to have both options for people. But I think for the majority, people liked the information, kind of the work being done for them in terms of here's who you're matched with, here's, but that only worked because the clinician that we mostly worked with at Prickly Pear, I mean, I am like a big fan of hers now after hearing so many wonderful things about her. But we really saw that what happened in those sessions where people were dealing with stuff from COVID, but COVID had triggered some old things that had happened that people had just never had access to mental health services to address. Here's some of the feedback from people that have completed services. So we only have about 10 people that are done with services. So this program is still it's still chugging. That's why I don't have a lot of outcome data to share. I'll just tell you, kind of from administering this program, one of the things that we've seen is that advocates are really busy, and anything you can do with a program like this to basically make it as easy as possible for them to participate. So again, on a second iteration of this, what we'd want to do is get the organizations to give people work time to do their session. Or we'd want to make sure all of our providers had evening availability consistently or weekend availability consistently, because many of these providers were counselors themselves who were seeing their own clients during the day. Oh, Vanessa, that is such a good question. So, I mean, this is something we're just learning on this project. There is some evidence from nursing and some of so, when we look at our workforce, we're looking at general social work or nursing, other first responders to understand, they're a little farther ahead of us because they typically get more resources in terms of how they've dealt with occupational issues. So the evidence I've seen about external providers versus the internal EAP is from nursing. I'll see if I can dig up this specific research. If there's a more focused question on that I can chime in on what we've learned. We don't have anything published about this yet, but it's something that's definitely come up again and again. Okay, and here's what we've learned so far from people that have completed about what we'd improve. Time slots didn't work for some people. For some people, the provider was not a good fit. Yes, I'll read the questions aloud. So the previous question was about where can we access research related to counseling for advocates preferring external EAPs? And that's what I said, kind of came from nursing. We also have had a lot of people that just didn't have time to participate. They signed up initially and then there was the big storm in Texas, or everybody went back to the office, or, or their kids were at home with them. They had the same problem as their clients, right? They couldn't participate. So really facilitating that kind of experience by allowing workers to have the time. The other thing that came up was it wasn't enough sessions. And, this was a funding issue. I was worried about this from the very beginning. I know that there's a lot of evidence for brief counseling models, but on some of our other studies with survivors, we see session limits being a big impediment. So one of the big pieces of feedback we got was it wasn't enough sessions for some people. So having some flexibility in the session limit would be something we'd want to do